session, we will see how it's working. And so we have different groups, and so we will do the different exercises, comparison of two groups of patients treated by speech therapists and myofunctional therapy, including one with Froggymouth. And then you will see the big difference, of course, and how they react. This is really important, and like Froggymouth, you need to show how things work. So I'm so happy to see Eleonore here so that we can carry out this study.
Thank you so much. So thank you for being here today, and thank you to the Froggymouth team for inviting me. So the study I'm going to present was carried out as part of a thesis that will be defended next June for my speech therapist degree. And the title was given by Guillaume just before. So the objectives of the study, we wondered what benefits could we obtain from speech therapy rehabilitation of dysfunctional swallowing with the Froggymouth device compared to conventional speech therapy inspired by myofunctional therapy in patients aged between 5 and 15 years. So we hypothesized that the Froggymouth would allow speech therapists to perform shorter and more effective atypical swallowing rehabilitations with a higher rate of automation of the praxis at the end of 12 weeks of treatment. So let me present the method. So first, I just want to specify that this work is not evidence-based practice, and I'll give the reasons later. So two groups of patients have been constituted, and from SLP's waiting list, sorry, and 30 participants received Froggymouth rehabilitations, but the SLPs were allowed to give also some exercises taken from the control group protocol, depending on patient's needs. And 12 participants received a conventional myofunctional therapy. The protocol was suggested by an SLP that uses it frequently. So the study took place over 12 weeks with a follow-up appointment every 4 weeks. So as you can see, the first appointment was called T0, and 4 weeks later, T1, 8 weeks later, T2, and 12 weeks later, T3. And between every appointment, the patients had to wear their Froggymouth or to realize their exercises daily. So here you have a table that presents the clinical signs or the variables recorded at T1, T0, T1, T2, and T3. So first, there is a general facial appearance test, and it was the engraving assessment. And the SLPs had to observe the relaxation of the lower face and to observe if the patient had dermatological signs on the lips. Then there was a swallowing assessment, and the SLPs had to observe the labial-chin contraction or chin occlusions, and if the patient had tongue thrust, so if it was anterior, lateral, or total. And at the end, there was a speech test, and it was supposed to be the automation test. And the SLPs observed if there was a tongue thrust when the patient was counting aloud from 1 to 20. And only at T0 and T3, there was an evaluation of the type of breathing, if it was nasal or mixed. At the end of each follow-up appointment, the speech therapist had to evaluate the evolution of the swallowing. So 3 stages were proposed. Stage 0 was when no improvement has been noticed. It means that the patient had still a full atypical swallowing. Stage 1 was when the patient engraved the correct praxis, but did not automated it. And the stage 2 was when the correct swallowing was automated, and so the atypical swallowing was considered as rehabilitated. But finally, it's important to note that we could conclude that the swallowing praxis was automated only if the patient had a good general face appearance, no labial-chin contraction, artisan occlusion, and no tongue thrusts when swallowing and speaking. But the praxis had to be performed correctly, consciously, and unconsciously. In fact, it may happen that these clinical signs are realized perfectly when the patient is realizing the conscious swallowing, but right after, when he doesn't pay attention anymore, we can observe a labial-chin contraction or an open mouth or a tongue thrust, and in these cases, we could not conclude that the praxis was automated. So in this study, the patients who automated the swallowing praxis did not show any opposite sign throughout the speech therapy appointment. So let me present the results now. So the main results for the Froggymouth group show that at T0, 100% of patients had an atypical swallowing. And you can see that at T3, it means after 12 weeks of treatment wearing a Froggymouth, 38% of patients had understood the swallowing pattern, the swallowing mechanism, but had not acquired automation of the new praxis. It means that they were still at stage 1, and 62% of patients automated the good praxis. Consequently, 0% of patients showed no signs of improved swallowing, And the statistical analysis shows a significant difference between the different times of the protocol with a p less than 0.001. Now the main results for the control group. So we can see also that at T0, 100% of patients had an atypical swallowing. And at the end of the 12 weeks of treatment, 17% of patients showed no sign of improvement. So they were still at stage 0. 75% of patients understood the correct swallowing praxis but did not automate it. And 8% of patients automated the good praxis. And the statistical analysis shows a significant difference between the different times of the protocol with a p less than 0.002. So here we can say that even if the results are significant, we can see that the Froggymouth group had better results than the control group. Furthermore, according to Dr. Fellows' recommendations, we included into the protocol the possibility to realize a Styloglossus stimulation at T1, T2, and T3 if the patients had difficulties engraving the new swallowing pattern. And this gesture helps the tongue to move backwards and upwards if it has difficulties to do it by itself. So the SLPs noticed that right after the stimulation, the good praxis was engraved for a lot of patients, while the first 4 weeks of treatment had not necessarily been effective. So we can wonder if performing this procedure at T0 could have allowed all patients to begin the treatment with functional styloglossus muscle and save time in rehabilitation. So these are the main results, but I would like to present other significant results. So here for the general face appearance, we can see that for the relaxation of the lower face and dermatological signs on the lips, not all patients do these signs at the beginning of the treatment, which means that it's not a criteria to diagnose an atypical swallowing. At T1 and T2, we can see a positive impact of the rehabilitation for both groups, but the Froggymouth seems to have a better effect on the action of the trigeminal nerve throughout the treatment. And the progressive disappearance of these signs indicates an engrammation acquired or in the process of being acquired. It depends of each patient, but it's they do not attest of an automation of the praxis. Now for the labial-chin contraction, we can observe that 100% of patients presented one at T0. However, the Froggymouth provides better results because, as you can see, 8% of patients only at the end of the protocol still had one against 42% of patients of the control group. Furthermore, the results show that the Froggymouth helps to reduce lingual interposition or tongue thrust more significantly because no more patients of this group presented one at T3 against 42% of patients of the group control. So even if the results here are significant, it's important to compare these results with those obtained at the speech test, because as you can see, 15% of the Froggymouth group still had one at the end of the protocol, and 33% of patients of the control group still had one. And so the results are not the same for the swallowing assessment and the speech test. It means that the absence of tongue thrust in one context does not prevent its presence in another. And to evaluate the automation of the correct swallowing praxis, it's important to evaluate the absence of tongue thrust in both contexts. So I would like to discuss a bit about this study, because as I said before, it's not an evidence-based practice study. First, because I was not allowed to meet the patients and to manipulate the Froggymouth as a French student. And for that reason, we asked SLPs to integrate the protocol and to realize the rehabilitation. So one speech therapist was assigned to the Froggymouth group and 3 were assigned to the control group. And as we just saw, our variables are subjectively analyzed. And so several evaluators lead to biases. And we can see also that it's a small cohort because it was not possible for SLPs to integrate more patients into their daily schedule. Then both groups are not age matched. As you can see, the Froggymouth group is 8.6 years old and the control group is 12.1 years old. But this can be explained by the fact that younger children can be rehabilitated with a Froggymouth, while SLPs often meet patients between the age of 10 and 15 years. And finally, the control group's protocol could be discussed because it's one selected among others, but it could be another one. And now this study also has some positive aspects. First, because the results confirmed our main hypothesis. And so the Froggymouth is a good device to realize shorter and more effective atypical swallowing rehabilitation in speech therapy. And it's also showed that it's possible to rehabilitate patients under the age of 7. And so the objective of the study here was not to discriminate one type of rehabilitation versus another, saying that now the Froggymouth could be the only solution for SLPs. But I think that the conclusion could be that mixing different strategies could be beneficial for the patients in order to offer him appropriate and effective care. And we don't have to forget that collaboration with other professionals is essential for a good care. So thank you so much for your attention. And if you have some questions, feel free to ask.
Thank you very much, Eleonore, for this wonderful presentation and 2 years of hard work to make a study like that. Yes. It is very important to do studies like that, to bring little evidence, even if, as you said it is not evidence-based practice. But the point was not, as Eleonore was saying, to say that we are putting into competition what speech therapists used to do since always with the passive approach of the Froggymouth. What matters is what's the best for the patients, what's the most efficient. And I think that you were doing it pretty right and pretty accurately in the meaning of trying to show that collaborating, adding passive approach and an active approach is probably what is the best for the patients. And again, that's always what we are all wanting, having patients that are re-educated as quick as possible. I think that there's, you can ask so all your questions about the study or on the chat right now, and we'll have also, like for all the other speakers, the publication on the Facebook group where you will be able to ask all the questions. Probably that we will have more detailed results after Eleonore present her thesis, because right now it has not been presented yet, so there is stuff that she cannot present. She still has to get her degree. I am sure that after such presentation, there is no doubt about that. No one is having doubt about that. You are getting congratulated for the presentation and also for your English as well.
Thank you.
I was also seeing a question that I think really matters and that is often coming and that is jumping a little bit on what you were saying and you studied about the breathing and the nasal breathing by itself. Many people may say that because of the gap that there is between the two lips when we're in the Froggymouth might be stimulating or making possible the mouth breathing, which we are all agreeing that we want to find and that we disagree about. That's exactly what is so important, and we will be speaking about that in more detail in other lectures further today, including the lecture of Dr. Phobos, but it is the posterior joint to the posterior seal, the joint posterior, so the posterior part of the tongue that is raised, and this is what is making impossible the mouth breathing. That's why breathing the Froggymouth during 15 minutes per day is not at all making possible the mouth breathing. We are all agreeing that we are fighting the mouth breathing, but we know that the posterior seal, joint posterior, is by far the most efficient. It's also the work of Jean Delaire about that. That is very interesting, and that I can only advise you to go check. There was a question that was arriving about the Styloglossus stimulation, but we were already answering that after the presentation of Eleonore Quillet. So I just advise you to go see it in replay during the next 7 days. You have the answer of how we make the stimulation with the mirror or with a little pen on the posterior part of the tongue right now. I think that people are astonished by their studies by itself, but we are not having that much questions except about the protocol by itself. I think that after the publication of the thesis, you will publish further details because on all the studies, what's the most interesting is to also see exactly how it is done. When we have short amount of time like that, we are presenting the results, see what we can do. Yes. Then what matters for people that want to dig a little bit, or want to dig, or want to see exactly what it is. It could be about more detailed statistics. Maybe that we can publish that also on the Facebook group. That is only closed, of course, for practitioners because it's not stuff that we share with patients, of course. Yes. To be able to answer everybody the questions that unfortunately we cannot answer for the moment. Yes. But she needs to get her exam. Come on, guys. So we are thanking you very much, Eleonore, to have joined us, and especially joined us in the Froggymouth studio today for making this lecture. And we hope that we will continue to collaborate, maybe make an article and come on an article to publish the results. We never know. First, the degree, and we see later. Thank you very much, Eleonore.